We're going to go ahead and get started. My name is Susie Vaughn. I'm the president of Indiana HIMSS. I'm an RN. I am the program director for Meaningful Use at the Community Health Network in Indianapolis. And I want to thank the university for allowing us to participate today. They've been great to work with, and it also helps us reach a goal of getting out into more regional events. And I've also been asked to talk a little bit about HIMSS and Indiana HIMSS. HIMSS stands for Healthcare Information Management System Society. It is a global organization. It's cause-based. It's not-for-profit. And it was founded over 50 years ago, so technology in healthcare is not as new as we think, but of course the focus today is on information technology. When I think about HIMSS and why I continue to be involved in that, I think of three things, and that is the diverse membership, the educational and professional development opportunities, and then the networking opportunities. The membership includes clinicians, educators, lawyers, financial experts, healthcare executives, vendors, IT professionals. Everybody brings their expertise to the table, and it's important to get that broad-based feedback and learn from that. The educational opportunities I think are high quality. I think they're easily accessible. I think that I've benefited from them professionally many times, and they come in a variety of formats. It can be through conferences such as these, regional, local, national, even international. It can be through webinars and articles and journals and online information. The networking is important, that events like this where you are able to meet new people and touch base, and then later, in my job, I may wonder about, I wonder how they're doing something at this place or that. So the fact that I've been able to connect with them at places and events like this, it opens that door and it starts a conversation. Indiana HIMSS is our state chapter. It is considered a medium-sized chapter. It's about 835 members. We do at least a couple conferences a year. We are really excited that we're going to be the pilot chapter for a webinar program that will use the HIMSS format. We plan networking activities, sponsored events, and I know that there's a lot of students in here, and we do provide scholarships. This program started about 3 years ago. We just awarded 4 scholarships, and this is for undergrad, graduate, and we have one that we designated for part-time students. And the other thing that we just did is that we are sponsoring a veteran, an Indiana veteran, to our national conference in Chicago in April. We were really proud and excited to be able to do that. So there's different levels of membership, but there is a nice student discount. I think it's $30 for full membership to everything that HIMSS has to offer. And if you have any questions, I'll be glad to answer those, and we do have a booth, but please reach out. Thank you.
All right. Okay, we'll find your slides. All right, welcome back, everyone, especially after lunch. And thank you for attending the plenary presentation this afternoon. It's my pleasure to introduce Dr. Brian Dixon. Brian is currently engaged in leveraging health information exchange as a platform to enable secondary use of electronic clinical and administrative data to improve continuity of care for military veterans. In his day job, he is an assistant professor at IU's Richard Fairbanks School of Public Health and a research scientist for the Health Services Research and Development Service of the U.S. Department of Veteran Affairs and also the Regenstrief Institute in Indianapolis. I've asked him to also explain why he has a wonderful drawing on the back of his navy blue jacket. In case you haven't paid attention, he will do that. Please join me in welcoming Brian Dixon to HITS and USI.
Thank you. No, it's not that one. Let's see. Maybe they already have it pulled up here.
Okay. Is this one?
Nope, that's not me.
Okay, we should find Brian's presentation first, so...
I do have it on my machine if we need to hook up my machine. but,
Okay,
I did bring that, so let me
Okay.
know.
all right. Let me try and find it, and...
Okay. Well, while you do that, I'll explain the jacket. So I want to thank the planning committee for inviting me to speak today. It's great to be home. This is where I grew up. So I live in Indianapolis now, but actually lived in Evansville most of my life. Attended and graduated from Harrison High School on the east side of town. So it's nice to be back in Evansville. And so I will explain to you my jacket. So raise your hand if you were here at last year's HITS conference. So, okay, so a fair number of you. So you remember Regina Holiday, who was the keynote speaker. She created what's called the Walking Gallery. And I became an official member of the Walking Gallery this past February at the HIMSS conference in Orlando, which is where it was in 2014. And so I'm a proud member of the Walking Gallery. And for those of you who are unfamiliar with it, I will simply say, Google Walking Gallery, and you'll find the YouTube video that they produced last year, which is phenomenal, that talks about the Walking Gallery and its origins and what it represents. But it's those of us who attend conferences like this who try to be advocates for patients and getting patients access to their data, patients engaged in their healthcare, patients engaged in health IT. And so I was really pleased that Regina invited me to joined the Walking Gallery and created this jacket for me, which represents a picture, it's sort of a self-image of, she painted me as sort of holding up the torch from the Indiana state flag as a beacon for health IT, given my involvement in a lot of health IT activities that I do, and I'll share some of those with you today. And so I met Regina 5 years ago at a conference sponsored by CMS in Baltimore. And I had to follow her. And so I'm really glad that Pat talked this morning, because her talk was, you could tell, it's an emotional story that she tells. It's really hard to be the next speaker after like that when I'm coming up here to talk about research and stuff that's less emotional. So, okay, no problem. We'll get my slides out here. And while we're doing that, we'll zip through the first couple, and I'll cover them in my remarks. So I have to always start off with a disclaimer, because I am, given my work at the VA, I am a federal employee. And so anything I say today is attributable to me and only me, and not the VA or the federal government, or any of my sponsors of my research, which are also listed in my slides. And my work, I have 3 jobs essentially, and they're all fun ones, and they're all around doing research on health information technology, various systems, and their impact on both individual and population health. Thank you. So get this fired up. Plug in whatever. And so I'm very excited that what Susie just said about the Indiana chapter sponsoring a veteran to go to HIMSS. That makes my heart warm for my passion for improving veterans care. Okay, so we will, sure. Let's see if this will work. There we go. Okay. So this is me and, oh, this won't work because of the, I'll just stand here at the podium. Okay, so again, disclaimers, VA employee, I said that. Okay, so my research is in these three intersecting areas: public health, health services research, and biomedical informatics. And I forgot to ask, if you're a physician, raise your hand, because I'm going to talk about a lot of physician stuff today. So let me see where the physicians are in the room. Only a couple. Okay. Well, then I'm probably not going to get any tomatoes thrown at me, which is good. But I work a lot on design and use of systems to support individual patient care, usually with physicians, but also I do a lot of work with the local and state health department to focus on population health in support of that. And then my work at the VA is population health, but in more of a clinical population health context as opposed to the health department, which is sort of, the geographical population. So my agenda is to really talk about what I see as a problem with electronic health record systems as they exist today, as we're pushing them out into clinical organizations. And that is what I hear constantly from physicians, mostly physicians, but also nurses and other clinicians as well, is that these systems are not meeting their needs. So the chief complaint is that EHR systems, as they exist in the marketplace today, have poor usability. And I'll talk about what that means. The symptoms of this, we'll go over this, include the disgruntled comments I hear, clinicians' avoidance of systems, and alert fatigue. Also, I'll talk about some treatments that we're working on both at the VA and at the Regan Street Institute to improve workflow, to improve the design of health IT systems, and some threats to adherence to these treatments, which include medical scribes, academic stuff that's going on in the academic medical center world, and meaningful use. So you say, but Brian, we don't have a problem because there's lots of adoption. You may say that. You may argue that. And it's true. The data show that we are adopting systems into organizations, right? So these are numbers from the Office of the National Coordinator. From the American Hospital Association's annual survey. And it shows that different functionalities that are available in electronic health record systems are being adopted. They're being reported by hospitals as being implemented into these organizations. And so we've made huge progress in getting CPOE adopted by organizations, etc. Even the HIMSS own model, which has slightly more recent data through the end of 2013, shows that there's been quite a bit of adoption, right? There's only now less than 6%, probably at this point, slightly less than 5% of hospitals that don't have anything that's electronic. But still, the adoption isn't fluid here in the sense that there are different stages that people are at. So some people have decision support in CPOE, others do not. But things are changing. On the physician side, the same is true, right? So this comes from the National Ambulatory Medical Care Survey of physicians, and it shows that over half of them have reported adopting a meaningful use certified electronic health record system for use in their practice. So you say, that's good, that's adoption, that's what we're after. And again, HIMSS data also shows the same thing. There's now less than 10% that have only a paper chart in their medical practice. And there's lots of other, and people are moving up the stages towards stage 7, which is an HIE-capable sharing data between EMRs, etc. So there's a whole continuum here, and people are moving up that continuum. And you say, that is great. And I say, yes, we're making progress on adoption. However, what we have going on today is organizational adoption of systems. And then, of course, there's everything below the surface, which is trying to use them to actually impact patient care. And that's where we're running into problems. At least I see it in my research and talking to physicians and reading evidence-based reports in the literature. There are lots and lots of challenges with these systems. And let me share some of that data with you now. So I see several signals. So to me, there are different signals, different symptoms that this is a big problem that we need to tackle. Here's the first one. How many of you saw this letter from about 5 months ago from the AMA? Okay, one, maybe a couple people in the room. Okay, AMA put out a big splash, a big press release that built on some previous work that they had done with the RAND Corporation, but they basically said the systems that we have are not usable, and we need changes. They actually sent a whole list of recommendations to the federal government for things they would like to see the Office of the National Coordinator do to try to fix EHR systems. So this is one sign or symptom. Also, and what let me give you a definition then. What they're saying is that these systems don't have the usability that we need to get our work done in an effective way. So usability is generally defined by Jacob Nielsen, has a wonderful book, and he's an excellent scholar in this area. And he describes it as all aspects of a human's interaction with a system. Now to me, that's kind of broad and all-encompassing. Great vision, but something that's more practical actually comes from an article that was in the journal Bioinformatics a few years ago that says it's the extent to which a product can be used by specified users to achieve specified goals with effectiveness, efficiency, and satisfaction in a specified context of use. I like this because it's much more approachable and understandable, at least to me, and it makes it measurable, right? Most people, when they think of usability, they think of, well, I don't like the fact that it's a blue screen. I'd rather have it red. They think it's just all about user satisfaction, pretty colors, and how it sort of makes them feel. But usability is actually more tangible than that, and you can measure it because it has various dimensions as defined by Nielsen and others. It needs to be learnable by novices. So if we throw a brand new nurse in front of a nursing documentation system, he or she should be able to easily learn the system. They may not be able to do everything with it from day one, but they should be able to learn the system easily without having to sit through hours and hours and hours of training. We have to get away from that model. Systems need to have low error rates. We should not have systems that facilitate people making errors, right? If these systems are truly going to impact quality and safety, then they can't facilitate errors themselves. They need to be efficient. They have to support workflow, right? We're in a system, I know we're moving to value-based purchasing, but today we're still in a system that largely rewards us by seeing as many patients in a day as we can. So the systems have to be efficient. Also, they have to lead to satisfaction. That's only one dimension. And then finally, if you're think about physicians who come into a hospital sometimes, but they're usually in their practice. When they walk into that hospital, they should be able to pick up and use that system, even though it may be weeks or a month since they were last in that hospital. All right, so other symptoms of poor usability besides the AMA call to action. So I want to tell you the story about Dr. Soper. Now, Dr. Soper, she is an OBGYN, or was an OBGYN in Indianapolis. She was actually my wife's OBGYN for our second child, and she was a great OBGYN. We loved her, and we were very happy with her. And then one day we got this letter, and the letter said that she was quitting her practice because of the electronic health record. So, of course, my wife had to grab this letter and run and show it to me, and she said, "You made my OBGYN quit!" And because I work in health IT. And I said, well, it's actually not me, it's IU Health, but that's another story. But I said, I don't think the EHR made her quit. And but it's funny, right? Because she said in her letter to all of her patients over the years, I'm quitting because of the EHR. So I'm just curious, how many of you know a physician who's quit or retired because of an EHR? Yeah, see, there's actually hands going up. This is a real thing. It's not imagined. So why? Why is this happening, right? What is Dr. Soper afraid of? And I think she's afraid of this. This is an article that came out in JAMA's Internal Medicine just a couple months ago by the former director of medical informatics at the Regan Street Institute, Clem McDonald. Dr. McDonald is now at the NIH. He's at the Lister Hill Center for Biotechnology Technology or something. I can't remember. It's Lister Hill is all I say. But he's in a limb. And Dr. McDonald did a great study where they surveyed physicians about the impact of EHRs on their daily tasks that they have to do as clinicians. And as you can see, the big kicker here is the bottom line. On average, how many minutes of free time have you lost in a clinic day because of the EHR? And look at that. Over an hour has been lost, right? So again, you can argue, yes, this is self-reported data. However, a ton of physicians said that they're losing more than an hour of time, right? And if you're supposed to see, 5 or 6 patients in an hour, that's a huge loss. So you have 2 choices, right? You see fewer patients and have less revenue, or you stay extra after the workday to get all your documentation done in the EHR. And that's what's frustrating to users, right? It's really frustrating to me that nurses spend a lot of time entering data into a system that the doctors never look at, right? That's exactly what happened in the Ebola case down in Texas, right? The MA and the nurse documented that the person had recently come back from Africa, but the physician never looked at it. So let me give you an example now, taking you out of the medical context and taking you some of the work that our current director of medical informatics at Regan Street has done some work in, because he's a dentist, and that is the dental EHR. So this is a screenshot of a product dentists can buy for their electronic dental record. Right? It looks great, right? It looks just like the dentist office. So you're at first glance, you're like, this has to have great usability because it looks and feels like a dentist office. This should make them feel warm and fuzzy, and they should be able to know exactly how to use it. But when Dr. Schleier did some research did some usability testing with dentists on how well they could learn to use the system, he found out otherwise. So what this is showing you the correct path for how the clinician should enter in that the patient has a missing tooth, right? They should start by clicking on the tooth that's missing, then go up to conditions, then choose which condition it's a missing tooth from the list of codes that are available, hit OK, then they go back and they say it's a current condition, and then that logs it into the system, right? So this is the optimal path. So then he invited in the usability test real-world dentists to use this system and tracked how did they do things, right? People were fumbling all over the place trying to figure out how to do it, right? So it is not very intuitive. Other signs and symptoms. A nice study from Partners Healthcare in Boston where they looked at over 150,000 clinical decision support alerts. They found that over half of them were overridden, right? And the things that we were putting in front of clinicians' faces and making them, choose what to do about it, were things that weren't necessarily, life-critical changing things. And so the physicians were just simply clicking through. And if users continue to get into the habitual pattern of just clicking through things, like the new user agreement for the latest iTunes software updates, right? How many of you read that every time they update it? Then one person. And then and there's always, I need to be heckled. Come on now. If they get into that habit, then they're not going to read the stuff that's really critically important to patient safety. And so override rates are something that should be tracked. They should not be this high, right? We should be giving clinicians alerts that are meaningful and in the right context that can actually change decision making instead of just something extra for them to click OK on. All right, so let me share with you a story from our work at the VA. So I'm at the Raudebush VA Medical Center in Indianapolis. I work in our HSR&D center, which we call the Center for Health Information and Communication, and we have a mission to, within the VA system, improve the electronic health record system and other health IT applications. And we also actually have a human-computer interaction laboratory at our facility, which is wonderfully, we deploy it, and we need something like that in order to be able to do usability testing. So from a study that my colleagues published last year in the Journal of the American Medical Informatics Association was entitled You, Me, and the Computer, which inspired the title for my talk. So in this study at our center, we did ethnographic observations at 3 different medical centers with 20 primary care providers. So what that means is we actually observed them in a clinical encounter. We actually videotaped it. And then coded it. We also did both semi-structured interviews with the physicians after the fact and before, and then we also did opportunistic interviews, which means that as we were sort of rounding with those PCPs, we also could ask them questions and as we were shadowing them. And then our main question that we were trying to answer is, how do providers use the EHR in an ambulatory encounter? So I loved Pat's picture this morning where it showed the doctor and the patient, and they were sort of, sitting like knee to knee and looking each other in the eye, and then you saw that laptop that was on a table, like in the background. Like you barely tell that there was a computer there, right? Because it was just the physician and the patient dyad. Right? But I don't think that represents reality. This is a picture from one of our videos. This shows an exam room, PC exam room in the VA. You can see the computer is not hidden behind, it's very present, and the physician is essentially sitting across from the patient, but the computer's in the middle. So the computer, the EHR that we've introduced, that our organizations have adopted, they've become a third person or third entity in the exam with the doctor and the patient. Okay? In this particular case, the physician, you can see, the physician is actually looking at the patient. The computer's to his left, but he has the EHR open to that patient's information and can refer to it during encounters. So we videotaped the providers, we coded it up. We wanted to see how much time did they spend looking at the patient, how much time did they spend looking at the computer, what were they accessing when they were accessing the EHR, what did they write down on paper, if anything, what were the nature of the conversations, did the physician show anything to the patient using the EHR? So here you can see there's things. And so when we measure the time, right, the green is the time that this particular clinician spent looking at the patient. The blue is how much time he spent looking at the computer. So this doesn't seem too bad. We asked physicians before we did any observations, we said, so, how do you use the computer during your exams? And a lot of them said, well, I occasionally refer to it. I don't look at it very often. I'm very focused on the patient. I provide the best patient care ever. I'm the greatest doctor, right? So all of the PCPs thought this. And so this one actually did a pretty good job. This is what I would call more an exemplary one. And then we also have this scenario where we have the provider who's sitting, this time the computer is to his right. The patient is in the lower left corner, completely blacked out. We obscure identities in these things. But here, the provider's focus is where? It's on the desk. He's got a whole bunch of papers that have notes and scribbles all over them. He has the computer turned so he can only see it, right? So what do you think the outcomes here when we measured his time were? The opposite. He spent most of his time looking away from the patient at the computer, looking up information. And what we found from our observations is that this provider was basically unprepared before he entered the exam room. And he was having to look up a lot of information about the patient, their past medical history, test results, and everything like that while he was in the room. And those of you who have used these systems know that they're not always super fast when you're trying to find information. So here's these two clinicians compared to each other. As you can see, the first clinician spent most of his time looking at the patient and only about a third or less looking at the computer. And the other physician is pretty much not completely the opposite, but certainly spent most of his time looking away from the patient. And so we basically found this dyad exists across the 20 providers that we observed. People generally fell into one of these two camps. So some summaries that we took away from the study is that we talked to physicians and we found that, the physicians that spent most of their time looking at the patients, they actually do some preparation before they go into the exam room. They actually look at the EHR before they go in. Sometimes they make little notes to themselves so they can remember certain things specifically that they want to talk about with the patient, but they're more prepared when they enter that exam room, as opposed to the providers who spent most of their time looking away from the patient. They were trying to access information on the fly, and they weren't as prepared. But of course, this is one study within the VA. Certainly we advocate that more studies should be done, in other systems and to find other things that work. We also need, clearly, interventions that optimize the EHR itself to better support preparing clinicians to enter the exam room and to be used during the patient encounter. One of the other nice things that came out of the work that my colleagues did is this conceptual framework. And I like it because it certainly highlights that usability is important, but usability is not as big of a factor as other things related to the organization and the way that the team functions, right? So this preparation before a patient visit can actually change a lot about how clinicians use the EHR during the exam, and also generally clinicians' approach to workload. What is the workload, and communication with other members of the care delivery team. So I like it, even though usability is not the, if we just change that, it's not like everything else. It alone is not a silver bullet that's going to change things, but it's something that's important because ultimately this is what we in informatics are trying to do. We are trying to make it so that physicians and computers working together is greater than all of the humans just trying to do it alone. So, what are some of the things that we're working on to improve this situation? So, we have a couple options. One option is we could try to change people, and that's pretty hard to do. We could also try to change the workflow so it matches the EHR perfectly. Well, we went out and bought a $30 million system and we'll just change everything we're doing to meet the system's needs. That's not what we want, right? We should optimize clinical workflow with the computer in mind but not be beholden to the computer. And we should change the EHR so it better supports best practices in clinical workflow. So the Regenstrief Institute, how many of you have heard of our institute previously? 1, 2, 3, I'll say a few of you. All right, so we're located in Indianapolis. We are considered a support organization to IU, but we're a separate nonprofit research organization. We have a variety of informatics training programs, and we focus on research and development. We also have a Center on Aging Research and a Center for Health Services Research, but we have a large Center for Biomedical Informatics. And basically, we feel it's our mission to do research to determine what works and what doesn't in the real world, in practice. We're very much an applied research organization. A little bit about our history. We started in 1972 when Dr. McDonald was asked to stitch together these things called the lab information system and the radiology information system and the XYZ information system within the public safety net hospital of Indianapolis. And so when he did that, he created what's become known as the Regenstrief Medical Record System. And then in a couple decades later, we began to stitch together EHRs in the Indianapolis area to create the Indiana Network for Patient Care, which originally was just called the Indianapolis Network for Patient Care. And then in 2004, the Health Information Exchange had become a little bit more unwieldy than what a small little research organization could handle. So along with BioCrossroads and some other corporations, that essentially became a spinoff into what is now the Indiana Health Information Exchange. So the way I usually describe it is if IHI and Regenstrief were one organization, we would just be the R&D division. But we actually happen to be separate organizations now with IHI doing all of the operations and maintenance and front office and everything for the Health Information Exchange. So I get no revenues from the Health Information Exchange. Wish I did, but I don't. No. So let me talk to you about some of the work that we're engaged in now to try to improve things. So I work in the context of public health, and this is the traditional public health reporting workflow from when the laboratory finds that a patient has, chlamydia or pertussis or something, they report it to the clinician, right? And then the clinician says, oh gosh, this is something I need to report to the public health department. So they run to their drawer, pull out the paper form, fill it out, and then fax it to public health, right? So that's what, and then of course, since Indiana is a dual reporting state, the lab is also legally obliged to report that to the public health department as well. So this is the traditional public health workflow, which I'm sure you know works great, right? What we decided to do was to try to improve reporting rates is we would use the Health Information Exchange as a platform to be an intervention to improve that workflow. And so now when the lab detects a positive case of pertussis or whatever the disease is, we pick it up in our automatic notifiable condition detector. So we get the HL7 lab result message. We say this is positive for whatever. And then we immediately can generate a pre-populated form for the patient that has the patient's information in it. And we can, along with the lab result and the doctor's information, and then we can push that out to them using the Docs4Docs platform that iHi operates. And then the provider can now not only get the result, but he or she can also get the pre-populated form. So all they have to do literally is kind of give it a once-over, and then send it into public health. And or document treatment, because the big thing that providers add to the mix is they can tell the health department that I'm aware of it, that I've written a prescription for azithromycin or whatever, and then they fax it into the health department. So that's our conceptual idea for the intervention. This is what the official state reporting form looks like. Has essentially 3 sections on it: patient information, the lab information, and the provider's information. Well, why should everyone have to fill this out by hand when we know who the patient is? We have a master patient index that connects EHR records from across the state for these people. So we know their address and their phone number and everything from the registration systems in hospitals and clinics. We know the lab data because we just got it from the lab, so we can put that on the form. And of course, we know the provider's name and where their office is and what their phone number is. So we can put all this on the form. We can put it into the existing Docs4Docs platform that providers already use today to receive their laboratory results, at least for those practices that have the D4D service, right? So we can pre-populate the form. So why not use technology in a more advanced way? So we have a controlled implementation where clinics will receive the pre-populated form in addition to the standard D4D clinical messages. We also collected data at baseline before clinics went live. We also have concurrent controls in the system, so some clinics who do not get the intervention. And then we have a mixed methods approach to evaluate this, quantitatively as well as qualitative interviews with the nurses, usually the nurses, and the MAs at the practice, along with the health department. So what are we measuring? We're measuring how complete are the data before and after the intervention in terms of what comes on the report from providers to the health department. How long does it take for diseases to be reported? Does it improve the disease investigation process? And does it improve reporting rates amongst clinics and or by disease? And then qualitatively, we're looking at users' perceived completeness and timeliness of the system along with workflow and, of course, satisfaction. So where are we with this project? We've finished baseline, and we turned on our intervention at the end of 2013. So we are just ending phase 2 of the project now, and getting ready to move on to phase 3, which is where we're actually going to be testing some new enhanced forms that we have designed in a very participatory way with clinicians and public health department that gets away from sort of the standard Indiana form and is more tailored to each disease. With additional information that the health department usually calls the clinic to ask about, but isn't on the standard form, again, to improve the entire disease investigation process. And so we're also beginning our analysis of the post-intervention data now. Another example, and I won't belabor this because it's a technical schematic, but we've also tried to improve workflow as it relates to medication adherence. And so we came up with an intervention that essentially, when the clinician accessed the care web server, which is inside the electronic health record, we went out and we gathered information from a personal health record, from the Regenstrief Medical Record System, and from a decision support service, and pulled all that data back to put into a dashboard to give to clinicians. This is what the dashboard looks like. Over here is the information out of the EHR. This is for diabetic patients we initially targeted, so it's their A1C, latest A1C levels, and then some cardiovascular measures around hypertension and lipid management, given its relationship to diabetes. In the center is essentially an adherence score. It's the proportion of days covered based on what has been prescribed to them, and based on pharmacy data that we get from a national source. And so we can see here this fictitious patient has bad adherence. You could be at 60%, which would sort of be like a yellow color, or above 80, which would be a good. And then we also pull in stuff from the personal health record to get the patient's voice, to try where they could put into the PHR questions or answer questions around, I'm having trouble taking my medications, and here are the reasons why. The idea is pull all this together in a single dashboard to spur the right kind of conversation, because patients don't often raise medication adherence issues. You don't walk into your doctor's office and say, I haven't been taking my meds. Even when physicians ask patients, are you taking your meds? We know people lie, or people are embarrassed about it, especially if they have financial situations where they can't afford the medications. We know this stuff happens in the real world. And so we're hoping this can shed some light. So we've piloted this within the Eskenazi Health System in Indianapolis. We've also done some other things with Eskenazi's provider order entry system. Another look at adherence is when the providers are entering their orders and getting ready to check out, or reviewing orders, we can put the same kind of PDC calculations with the red, yellow, and green coloring over here on the right to alert the physician to potential problems. So this is another way at stabbing at the same issue that we're all dealing with, which is adherence and challenges with adherence. We've also created some technologies within the Eskenazi system that allows the physicians, as they're typing in their notes, to do real-time natural language processing. So in this example, the physician typed in family history of breast cancer, hypertension. They're going on to type their note. Well, within a couple seconds, the system realizes they typed in family history of breast cancer, which happens to be exactly the inclusion criteria for a research study that's going on. So we can alert the physician right then and there, over here on the right-hand side, say, hey, would you like to, would you be okay with us approaching this patient to enroll them in this clinical trial? But we can also do lots of other things with this NLP. So for example, if the physician says, well, I'm thinking about, prescribing lisinopril for this patient, we can automatically detect that, stick a lisinopril order in the order cart, so when the next step of the workflow, they go to do their ordering, it's already there for them. They simply have to verify the dosage, and then sign off on the orders. So lots of things we can do with sophisticated tools. All of this we do through a program we call Medical Gopher, which has been around for decades. If you're interested, here are a couple references I would point you to, and my slides are available on the website if you'd like to see this later, so you don't have to jot down all this journal stuff now. So those are some of the things that we're trying to do to make the EHR better support clinical workflows, so the real-world workflows. But there are some risks to basically us being able to accomplish all of this. The first is medical scribes. So I don't know how many of you saw this article in JAMA from about a month ago that criticized the rise in medical scribes, but I think it's spot on. Because these are unlicensed individuals and that are basically serving as liaisons between the physician and the electronic health record system. So there's all kinds of talk about how we can, save money at the health system if we use these scribes to enter in all the information. And oh, by the way, let's go ahead and give them the decision support alerts, and let's go ahead and have them enter the orders, and let's go ahead, so this article is saying, boy, that's dangerous if we're giving unlicensed people the power to review the decision support alert and deal with it, because the physicians, again, they don't have time to, because they're trying to deal with the actual patient encounter. And so there's now we're expecting 20,000 of these folks to be working, at least that was one estimate, by the end of 2014. I don't know if that's actually a real number or not, but there's a lot of these people in the system now. And so this is a threat to us being able to provide EHRs that actually support real clinicians in providing clinical care. The other thing is, I don't know how many of you are aware of this, but when a few years ago, RAND did a systematic review where they looked at the published literature in health informatics. And they found that 3/4 of the evidence base for the use of electronic medical record systems came from 4 big institutions: the VA, Partners Healthcare in Boston, the University of Utah in Salt Lake City, and the Regan Street Institute in Indianapolis. So back a few years ago when the study came out, we all patted ourselves on the backs and said, look, we're pretty awesome. Well, now we're facing the situation where these large historical academic medical system centers with a homegrown EHR they're dying. So Partners Healthcare has already moved to Epic. LDS Hospital right now is going through the transition to Cerner. We will know at the end of this week whether Eskenazi will ditch our system in favor of Epic or Cerner. It will be one of those. And so all these great tools, the innovations, the HelpNet system, for those of you who are familiar with the work out in Utah, or all the cool stuff that Partners did in Boston, those innovations that they put into the EMR are not available in Cerner. They're not available in Epic. They're not available in NextGen. And so we as academic medical centers are in a state of transition where we have to figure out how we can partner with EHR vendors to get our innovations into the systems that you all use in practice. And that's a big challenge, because the vendors say, yes, give us your idea and your IP, we will sell it, and then if you're lucky, we'll give you $1 next year. That doesn't fund research, right? And the NIH is not giving us a lot of money these days to come up with the next generation of electronic health record systems. And so this is a big challenge for us, and we haven't quite figured it out yet, right? What happened at Boston, which was on the front end of this, is that a lot of their academic folks in informatics left and went to other places. I don't know what's going to happen in Utah, and I hope the same thing. I hope we figure it out in Indianapolis. Meaningful use is also a threat to us, because meaningful use is pumping out version 1 of electronic health record systems. And I don't see any incentives in there for version 2 or 3. And that is because when we work with our health system partners, and we work with more than just Eskenazi, but our health system partners tell us, I have all of these deadlines to meet for meaningful use stage 2. I cannot possibly support your research study, your new research study. I can't possibly find time to work with you on innovative new things, because I have got to get these things done and implemented and out the door by the end of this quarter, or else my position is toast. And so that's what we're facing. So that is a major threat to innovation, in my opinion. Also, analytics, right? How many of you have heard of big data, right? This, to me, is actually a threat to improving the electronic health record system, because a lot of the health system partners are not just trying to get meaningful use stage 2 done, but they're also emphatically, enraptured by the potential of analytics, and they want all of us to get on board with their analytics projects and create dashboards that, for the executive team, right, instead of trying to improve the workflow and the information systems that are delivered to the care team. So, again, my opinion. So to recap, there are basically two kinds of EHRs out there. There's those that are bad and those that are worse. And then the policies that we have today have helped us with adoption, no doubt about it. Organizationally, we are adopting systems like mad. But we are doing that at the expense, I think, of clinical workflow and potentially stifling the development of the next generation of EHRs. So the solution is we need to work on both the system and the workflow. And this, of course, will require R&D, and it will require organizations to also invest in evaluation. So I spend some of my time working with health systems to say, here's how you can basically do evaluation on a shoestring budget so that at the end of the day, you know whether that $30 million system you just bought is actually performing for you. So, right? You're not alone, right? We are all Spartacus in this adventure of electronic health record adoption. So, quickly, some acknowledgments. These are all the places that fund my current research, and I am eternally indebted to them for their support because I like what I do, and I want to keep doing it. And with that, I will stop and entertain your questions if we have time. Thank you very much. Peggy. Do we have time for questions? Well, until someone who tells us not, feel free to ask questions. Oh, you have a mic. Okay. Are there any questions?
Do you ever see a time when all of these systems will actually speak to one another across the country? The general public had the misnomer that once they did all of this, they could go to California to New York and all of their electronic records would go with them and be accessible. And as we all know, that is nowhere close to being done. So I was curious of when you think that maybe you'll have the magic bullet that'll link all of these together. And
Well, I don't have the magic bullet to solve the interoperability challenge. I think there are still some real problems with interoperability. I could give a whole nother lecture just on that because that's what I do a lot of my day job in is in interoperability as well. And so there are some real challenges in getting the vendor, it's not just a vendor problem, it's not just a health system problem, but I see things like, for example, Anthem was one of our partners in the Health Information Exchange, and then they decided that they wanted to buy another, so they pulled out of our HIE and decided to buy an HIE technology because they decided to become their own HIE. So they feel like they can create an HIE business unit for their organization, and if they can define, they feel that they can define an ACO, and they can control everything within that ACO. And that reminds me of sort of the HMO era, the fallacies of HMOs from 20, 30 years ago, right? Our research has shown that even if you form a tightly knit ACO within a 1 or 2 hospital system partnership, your patients still have the ability to get care outside of your ACO. So at some point, you have to be able to access their information because it moves around with them. And so we have some major problems with interoperability. I hope that gets solved. We're working on a number of things to try to get there. We're actually having a lot of success at Regenstrief in non-U.S. countries solving interoperability than we are in solving it here. And there's a lot of system reasons for that. But I think that as the pendulum swings more towards value-based purchasing, and health systems and insurers and the like all realize that you are going to have to access data from other people's systems. You have to do it and figure out a way to do it, and you're not going to want to pay a lot of money to do that. To create hundreds and hundreds of interfaces, it makes more sense to invest in sort of a common platform for that. Then we'll get there. We're lucky we have we actually have more than one HIE in our state. Some other states have some HIEs. They're helping the situation, but we have more work that needs to be done. We need to make we got to create more services for the HIEs. We've got to lean more on the vendors to change some of their practices around selling interfaces. And we have to, make a shift more towards, I think, more towards some of these recent open source systems that facilitate HIE. So we're not buying a bunch of HIE technology from different places. So yeah, there's lots of things there's lots of that's happening there. We also still have a long way to go. Yeah, good question.
Hi, Brian.
Yeah.
James Simmons. What do you think the importance of HL7 is going to be when we look at interoperability as far as that, I guess, coded language that all of them can kind of decrypt or encrypt? And then also, what have we learned from other states' HIEs? I know that several have failed in recent history here. I think Wyoming recently, their HIE just kind of went under. What are we learning from those that are faltering, and what can we do better to leverage our HIEs to share that data across the broad spectrum?
Yeah, fantastic question. So to address your first question, there's no doubt in my mind that I mean, HL7 is the dial tone that folks should use. I mean, the vendor systems themselves use HL7. However, HL7 gets us about maybe 40% of the way there. So it can help systems exchange messages, but it doesn't help these dumb computers understand what's in those messages, right? And that's where coding standards become very important. Not just ICD, but the CPTs and the LOINCs and the SNOMEDs and the RX norms and everything like that. And the fact is that it's a lot of hard work to map your local terminology into those things. So HIEs can help with that. And then, so they can help with the semantic part of the interoperability. But, I mean, syntactically, there's some things we can improve with HL7, but I think it will continue to be the dominant standard for at least getting messages moved around. Then we still have the big problem of understanding what's in them. I think we are learning things from the failed HIEs of some states. We know that if the governor, for those states where the governor said, we're going to create the HIE at the state level and everyone will, work out of my office to do things, that's not a good model. That you have to, it's hard work, but important work to build trust amongst the CIOs, the CMIOs of the hospital systems, and the leadership at the clinical practices, so that at the end of the day, those people create a shared governance model and agree that, and recognize that they're going to have to pay something for the HIE. They have to invest something in it. Again, I don't think that it's one health system's or one practice's responsibility to pay for everything and to spend millions and millions and millions of dollars on it. But at the end of the day, they have to pay to support a common infrastructure and because they have to share data with each other. And so I think we're learning that in states where the governor's office led things, or in states where everything was really hinged on just the grant dollars, that's not a sustainable model. And so, and the ones that are thriving, I think, are models and continue to be models for other states. Yeah, good questions. Yeah.
What's the status of LOINC? And you might describe what LOINC is for those who might not know.
Oh, yeah. So for those of you who are unfamiliar with LOINC, it is it's the standard, the coding standard to describe what lab test was performed. So if you want to know what specific DNA test was performed or what specific white blood cell count test was performed, you can use a LOINC code to define that test. SNOMED, of course, is the complement of that, which tells you what the answer is, right? What was the result of the test? But LOINC encodes what the test is. So Regan Street is the home of LOINC. We have a contract with in full disclosure, we have a contract with NLM to produce LOINC and then give it away for free. So, we're not going to try to sell it to you. If someone tries to sell you LOINC, run away. We'll give it to you for free. But the status of LOINC is it continues to expand. We now have LOINC codes that not only encode what lab test was performed, but we're doing a ton of expansion in the genomic area, as well as questionnaires. So Pat mentioned the CAPS, scores, the patient questionnaires. We have lots of questionnaires now where the questions for that have been encoded in LOINC, along with answer codes. And so LOINC continues to be very popular. The challenge, of course, is getting hospitals to map to LOINC, vendor systems to embrace LOINC. That basically vendors will embrace LOINC as long as you do the hard part of doing all the mapping. And so we saw an initiative from CDC to pay for 500 hospitals in the U.S. to map their laboratory catalogs to LOINC, and that was great. However, you all know there's like 30,000 hospitals in the U.S. So we have a long way to go before all of them are there. We are also making progress with device manufacturers who now will actually have their devices emit LOINC instead of emit a local code that you would then have to map to LOINC. So that is good, but we only have a couple of those folks on board, but we're making progress, which we've been trying to do for years. We now actually have them, they're getting, and part of the reason they're coming to the table is because their customers are beginning to demand it. So you heard from Pat this morning that patients need to demand, right, a better healthcare system. Well, healthcare systems need to demand these vendors and device manufacturers do a better job of supporting not just HL7, but supporting the semantics behind what's in these messages. Great question.
Maybe I'm a little confused on the state of the industry, but comparing the sort of to the pharmaceutical industry, which self-funds its own research and things like that, why aren't the vendors themselves conducting research in their own usability of their own systems, and would a model like that kind of work?
So that is an excellent question. So I have had numerous conversations with vendors about usability. So in part, MeFuse actually has some requirements now around usability. They're a little weak. They could be stronger per the AMA letter. So I agree with what the AMA is asking for in terms of strengthening the requirements, and that the results of those tests be public. That's one of the things, right? So you have no idea. So Cerner has their EHR certified for meaningful use. That's great, and they passed the usability requirements, but you don't know what their scores are on the tests. And so those kinds of things, there needs to be more transparency. So a lot of the vendors will tell you, we have an R&D unit. We may employ like one scientist and a few people in a lab, and they test our products, and they probably do have people. They're probably not lying to me, but they do it in a very isolated way. They're not. Some of them are trying to listen to their customers and adjust and do things, but some of these companies have gotten so big where it's hard for them to change. And there's a trade-off between customizability of your system for your health system or your organization and standardization across the entire platform. And so there is some trade-off there, but I would love it if the vendors would actually support some of this research outside of their own employees. I think right now they have a few employees that do testing. Some of that may or may not be real usability testing, but they do have internal testers. But we're not to quite the state of pharma where they're willing to not only invest in their own scientists, but also partner with academics. A lot of academic medical centers that have proprietary systems, they have a clause in their contract that prohibits the academics from publishing the results of their studies, or disclosing information without it being approved by the company. Well, academics hate that, and of course it prevents some of this information from coming to light. And so it's in the vendor's best interest to keep doing that, but we have to break down barriers like that if we're going to have real strong partnerships between academia and vendors in the health IT space, which historically have not been very strong. Good question.
I think that's all we have time for.
All right, I've rambled on long enough.
Thank
Thank you
you.
very much.